Okay. So my topic of discussion is art of gonioscopy. So basically gonioscopy is a fundamental part of comprehensive eye examination and it helps in determining the topography of the anterior chamber angle. It is helpful in evaluation, diagnosis and treatment of glaucoma. So these are the various topics which we'll cover in this slide. In the presentation. So what is the need of gonioscopy? Basically, the light rays coming from the angle undergoes an optical phenomenon called total internal reflection at the tear AFS interface due to the curvature of the cornea. With the help of gonio lens, this interface changes to lens and air interface, and it permits us to view the angle anatomy. So indirect gonioscopy is the standard method of examination. It is done on a slit lamp in a sitting position. Whereas we have direct method of gonioscopy, which is a OT examination, and it is done in supine position. In direct gonioscopy, the observer can look directly at the angle and we get a wide panoramic view of the angle. It is particularly helpful in patients with nystagmus or irregular corneas or a patient planned for angle-based surgery. In indirect gonioscopy, the observed image is reversed by 180 degrees. So say if we are looking at the superior mirror, we are actually examining the inferior angle, but it is not crossed with respect to right and left. Indirect gonio lenses are a flange type and a non-flange type. Goldman type lenses with 1 mirror, 2 mirror or 3 mirror are flange type of lenses where its radius of curvature is greater than that of the cornea and hence a coupling agent is required while examining the eye. Whereas non-flange lenses like Poschner lens, Sussman lens or Zeiss 4 mirror lens are non-flanged and the radius of curvature matches that of the cornea and the tear film itself acts as a coupling agent. So coming on to the technique of gonioscopy, first we have to be careful of the patient settings. We have to make the patient sit in a comfortable, we have to make the patient sit comfortably in a supine, we have to make the patient sit comfortably in a dim illuminated room after applying a drop of anesthetic. Coming on to the slit lamp settings, the graticule of the slit lamp should be reduced to 5 mm or less to prevent any light-induced pupillary miosis. And gonio lens inspection should be done for any surface irregularities or lens crack or presence of any air bubble or small oily secretions which can obscure the visibility of the angle. And the lens is placed in the inferior fornix while the patient is asked to look in up direction or in down direction. And examination is done in primary position. So in the gonioscopy is always done dynamic. So in dynamic gonioscopy, manipulation is done and the patient is asked to look at the mirror and the lens is pushed on the sclera slightly tangentially to open up the angle. In cases of when we are using non-flange lenses like Poschner lens, indentation gonioscopy is done where axial pressure is applied on the cornea and it is necessary to distinguish from an appositional angle closure to a synechial angle closure. So in the second image we can see the angle nicely opens up after indentation. Normal anatomy of the angle starts from Schallway's line anteriorly and it extends up to the root of iris posteriorly. In between we have trabecular meshwork which has an anterior non-pigmented part and a posterior pigmented part which is the functional part. After trabecular meshwork we have a wide band of scleral spur followed by ciliary body band. A corneal wedge technique is used to identify the Schallway's line which is especially helpful in differentiating a pigmented Schallway's line from a trabecular meshwork. So there are various grading systems available. So we can, modified Chavez system is the most followed grading system. And then we have more complex systems like Spade system which gives a better understanding of the structures and anatomy of the eye. Coming on to the diagnostic uses of gonioscopy, it helps us to identify the type of primary glaucoma. It helps us to decide the need of iridotomy. It distinguishes secondary causes of glaucoma. It's helpful in identifying neovascularization of the angle and also to check the patency of the ostium after a case of trabeculectomy. Therapeutic uses of gonioscopy include laser procedures like ALT and SLT, and surgical uses include goniotomy, ab interno trabeculotomy, or any of the MIGS procedure. So one should be well versed with, should be able to differentiate between confusing anatomical structures like a pigmented sample, sample is line from a pigmentation of trabecular meshwork, a pathological peripheral anterior synechiae from a physiological iris process, a normal blood vessel of the angle from neovascularization of angle. And gonioscopy is also helpful to differentiate a plateau iris from angle closure disease with the appearance of double hum sign or indentation. Gonioscopy is also helpful in identifying development anomalies of the angle. Like here we can see disorganized angle and bridging synechiae present in the angle, which is pathognomic of Axenfeld-Rieger syndrome. In a case with a history of ocular trauma, we should rule out angle recession and cyclodialysis with the help of gonioscopy. And this, particularly in this case, it was a case of young adult with history of frequent and recurrent anterior uveitis, only to find that there was presence of caterpillar hair in the angle, which attributed to recurrent uveitis in the patient. So there are common errors which we must avoid is putting excess pressure, which can be identified by appearance of Descemet's folds, or doing under excess illumination, which can cause pupillary constriction, and doing under the effect of mydriatics. To conclude, always do dynamic gonioscopy under low illumination first to identify the type of glaucoma, then increase the illumination to visualize pathologies, and perform after tonometry to avoid artificial lowering of IOP. So secrets are always hidden, and gonioscopy helps us unravel hidden dangers. Thank you.